Imagine a scenario for a second. It's a Tuesday morning. You walk into a room, you extend your hand to shake a stranger's hand, and you sit down.
Okay.
The whole interaction takes maybe 3 or 4 seconds.
Yeah.
But in those 3 seconds, before you've even opened your mouth to say hello, that stranger already knows that you're iron deficient. They suspect you have a drinking problem you've never admitted to your spouse, and they have a pretty strong hunch your kidneys are struggling.
Wow. I mean, when you put it that way, it sounds
Yeah.
it sounds terrifying. It's like some kind of magic trick, right? Or one of those mentalist acts you'd see in Vegas.
It does. It absolutely does. But it isn't magic. It's actually the oldest trick in the book, specifically a medical book.
Mm-hmm.
Today, we are doing a deep dive into what is essentially the Bible of the bedside manner. We are looking at Hutchinson's Clinical Methods.
That classic.
We're focusing on the 24th edition, which is, the modern standard. But the lineage of this text actually goes all the way back to 1897.
That really puts it in perspective. I mean, Queen Victoria was still on the throne when the core philosophy of this book was first written down.
It's incredible.
And what is absolutely incredible to me is that despite us living in the age of AI, genetic sequencing, and MRI machines that cost millions of dollars, this book and the manual skills inside it are still the bedrock of how a doctor actually saves your life.
That is the core tension I really want us to unpack today. Because on the surface, it seems almost, archaic.
It does.
Why are we obsessing over the shape of a fingernail or the specific smell of someone's breath when we have, full-body laser scanners? Why does the old school method still matter?
That's the million-dollar question, isn't it? And the answer Hutchinson's gives us is, I think, profound. Technology gives you data.
Right.
It tells you what the disease is. It gives you a code or a label.
Yeah.
But clinical methods, the art of looking, touching, listening, tell you who the patient is and how that disease is actually affecting their life.
Ah, that's a great distinction.
It's the difference between reading a spreadsheet of stats about a person and reading their biography.
I love that.
Yeah.
And having read through this material, I have to say, I felt less like a medical student and more like I was at a detective school.
That is exactly the right framework. It is a masterclass in forensic observation. It's Sherlock Holmes with the stethoscope.
Right. So let's put on our detective hats. The text structures this investigation logically, almost chronologically, starting with the moment the doctor and patient first start talking, the history taking.
The interrogation phase.
The interrogation phase, essentially.
Though we try not to use the word interrogation with patients.
Fair enough.
But yes, this is where the clues first appear. And Hutchinson argues that the most critical moment is the very beginning. They call it the golden minute.
The golden minute. This
Mhm.
is the moment the patient sits down. And the text makes a very specific, almost counterintuitive recommendation here regarding what the doctor should do. It says the doctor needs to essentially shut up.
It sounds harsh, but yes, that's the essence of it. The recommendation is to start with what we call an open-ended question.
Okay, what does that sound like?
Something broad, like, tell me what has led up to you coming here today, or what's been the trouble. And then, and this is the hard part, you have to let them answer without interrupting.
Which is incredibly difficult,
Yeah.
right? I think I've read studies saying the average doctor interrupts a patient within something like, 18 seconds?
It's a reflex. It really is. Doctors are busy, the waiting room is full, and our brains are trained to solve the puzzle.
You want to get to the answer.
Exactly. If you come in and say, my chest hurts, my brain immediately screams, heart attack, acid reflux, muscle strain. And I want to start firing yes or no questions to narrow it down immediately. Does it hurt when you walk? Yes. Does it go down your arm? Yes.
It feels efficient. You feel like you're zeroing in on the target.
It feels efficient, but Hutchinson's warns it's a massive trap. It's what they call railroading.
Railroading.
Yeah. When you ask closed questions too early, you force the patient into your narrative. The text gives this brilliant cautionary example of this. A smoker comes in with chest pain.
Okay.
The doctor immediately assumes it's angina heart pain due to clogged arteries. So they ask, is the pain in the center of the chest? Patient says yes. Does it happen when you walk? Patient says yes. Does it feel tight? Patient says yes.
Sounds like a slam dunk diagnosis. It's angina.
It looks like it on paper. But because the doctor didn't let the patient talk, they missed the context. If they had just asked that open-ended question, tell me about this pain, the patient might have said.
Something totally different.
Something like, well, doctor, the pain starts when I walk, sure, but only after I've been digging in the garden for about an hour, and it feels more like a muscle pulling than a tightness. And it gets worse when I twist this way.
Ah, right. So it's a muscle strain from gardening, not a heart condition.
Exactly. The yes-no approach created a false positive. You found the disease you were looking for, not the one the patient actually has.
You fulfilled your own prophecy.
Precisely. The open-ended question allows the nuance to surface. It allows the illness, the patient's unique experience of their symptoms, to exist alongside the disease. You have to balance that need to steer the ship with the patients to let the passenger tell you where they want to go.
Speaking of nuance, let's talk about the language barrier. And I don't mean, French versus English. I mean patient English versus doctor English.
Oh, this is huge.
I was struck by how words we use every single day have completely different meanings in a clinical setting.
This is a huge source of misdiagnosis. You
Yeah.
absolutely cannot take a patient's words at face value. As a doctor, you have to be a translator.
Let's take the word dizzy.
Mm.
If I tell you I'm dizzy, you know what I mean? I feel a bit woozy. Maybe I stood up too fast.
But medically, the word dizzy it's useless. It's
Oh.
too vague to act on. Does the patient mean vertigo,
Which is?
which is the specific sensation that the room is spinning around you like being on a teacup ride that usually points to the inner ear or the brainstem? Or does it mean presyncope, which is the feeling that you are about to black out or faint? That points to the heart or blood pressure issues.
Two totally different organ systems, two different treatments, but all from one word from the patient.
Correct. And if you treat a heart patient for an ear infection because they said dizzy, you're in serious trouble. You have to ask, describe the sensation to me without using the word dizzy.
That's the key. The other one that made me laugh, but is actually quite serious, was the one with diarrhea.
Yes. This is a classic miscommunication. A patient says, "Doctor, I have diarrhea." The doctor immediately assumes they mean liquid stool. Watery.
Right.
But often, if you dig, the patient just means, "I went to the bathroom 3 times this morning instead of my usual once," even if it was solid.
So they're talking about frequency?
They are talking about frequency. The doctor is thinking about consistency. They're two totally different things. You have to ask the gross questions to get the truth.
And then there's the big one, angina.
Mm-hmm. Patients love to use medical labels they've heard from their neighbors or, seen on TV. My angina is acting up.
And it sounds official. It sounds like they know what they're talking about.
It does. But if a doctor just writes that down as a fact, they've failed. You have to strip away the label. Ask, what does it actually feel like when your angina acts up? And the patient might say, oh, it's a sharp stabbing pain right here when I cough.
Which is not angina.
Not at all. That's a chest infection or a pulled muscle. Angina is a crushing heaviness, a pressure, a completely different sensation.
So words are unreliable, they're slippery, but the text suggests that the body is more honest. This section on gestures as clues was fascinating to me.
Oh, absolutely.
The idea that a patient's hands are subconsciously acting out the diagnosis while they speak.
It's body language, but it's highly specific medical body language. When we are in pain, our body tries to physically counteract it, and those movements are almost universal across cultures.
Okay, so walk us through the cardiac squeeze.
Right. If someone has true ischemic heart pain, which is a lack of blood flow to the heart, they will often, without thinking, clench their fist and press it right over the center of their chest, over the sternum.
A closed fist.
A closed fist. It's such a distinct sign, it actually has a name. Levine's sign. It's the body trying to say, it feels like a vice is crushing me.
Now contrast that with heartburn or reflux.
Totally different gesture. Heartburn feels like a burning sensation rising up the throat. So patients will use an open hand, palm flat, and rub the breastbone up and down.
Ah.
It's a soothing motion, not a clenching one. You see the open hand versus the closed fist, and you already have a powerful clue about what's going on.
And then there's the gut pain. I think we've all done this one when we've eaten something bad.
The midgut colic. Yes. If you have cramping in the intestines, you will instinctively wrap your arms around your abdomen and squeeze, almost hugging yourself.
You're kind of leaning over it.
Exactly. You're trying to physically support the cramping muscles. If you see a patient doing that in the waiting room, you're already thinking abdominal obstruction or food poisoning before you've even shaken their hand.
Okay, so we're decoding gestures. But eventually, we have to deal with the personality attached to the body. The text has a whole section on difficult histories. And I have to say, the garrulous patient felt like a personal attack on some of my relatives.
We all know a garrulous patient,
Yeah.
the storyteller who cannot stick to the point.
Doctor, I think the pain started on Tuesday. Or wait, was it Monday? No, it was definitely Monday because my son came over and he always brings that casserole I hate and the dog was barking at the mailman.
And suddenly, 5 minutes of your 10-minute appointment are gone. The clock is ticking. This is where the detective has to become a bit of a traffic cop.
Right.
Hutchinson advises that with this specific type of patient, you abandon the open-ended question rule we just talked about.
Oh, you flipped the script?
You have to switch to closed questions. Did it start Monday? Yes or no? Is the pain sharp? Yes or no? You have to be, politely ruthless to salvage the consultation.
It's about managing time without being rude.
Oh.
Okay, then there's the angry patient. And this feels very relevant to the modern healthcare experience.
Yeah.
People are frustrated. They've waited 3 months for an appointment, and they've sat in the waiting room for an hour. They come in hot.
They do. And the natural human reaction for the doctor is to be defensive. It's not my fault the system is broken.
Don't yell at me.
Don't yell at me. But the text shows a lot of emotional intelligence here. It says, validate the anger, even if it's not your fault. Apologize for their experience.
So you diffuse the bomb.
Exactly. You say, I am so sorry you had to wait so long. That sounds incredibly frustrating. Let's focus on you now. Because often, that anger is actually fear.
Ah, that's a key insight.
They aren't yelling because they hate you. They're yelling because they're terrified they have cancer and nobody is listening. If you acknowledge the frustration, you lower the temperature, and then you can get to work.
Now, there is a new archetype in the 21st edition that definitely wasn't in the 1897 one. The well-informed patient.
Dr. Google.
The one armed with a stack of printouts from the internet.
The Dr. Google phenomenon, yes. In the old days, the doctor was the sole source of truth, the keeper of the knowledge.
The authority.
The authority. Now, patients have access to the same data, but not the training to interpret it. The text says the doctor's role has shifted from being a dictionary to being a filter.
I like that. A filter.
You aren't just giving information anymore. You're helping them sort the good data from the bad. It requires a different kind of patience, a different skill set, but it's crucial.
We can't leave the history section without talking about the hidden truths, specifically alcohol and drugs.
Right.
The text seems to imply that when it comes to these topics, patients, well, let's just say they fudge the numbers.
Fudge is a very polite word for it. They lie. Or, to be more charitable, they underestimate in a way that is profound. There is a massive stigma around addiction, and people deceive themselves just as much as they deceive the doctor.
The text breaks down the social drinker myth. This was fascinating.
This is a classic math problem for medical students. A patient says, oh, I'm just a social drinker. I have a couple of pints.
Sounds harmless enough. A couple of pints.
But the detective has to dig. You have to ask, a couple of pints of what?
Okay.
Oh, the strong stuff, the 8% IPA. Then, how often? Oh, most nights. Anything else? Well, maybe a whiskey or two before bed to help me sleep.
And when you add it all up,
When you actually calculate the units, that couple of pints turns into 70 units of alcohol a week. The recommended safe limit is 14.
wow, so they are drinking 5 times the safe limit, but in their head they are social drinkers.
Exactly. Their self-perception is completely divorced from reality, and that's why the text suggests using the CAGE questionnaire.
Right, C-A-G-E.
It's a rapid screening tool that bypasses the quantity question entirely and looks at the behavior around drinking.
Okay, walk us through it. C-A-G-E.
C. Have you ever felt you should cut down on your drinking? A. Have people annoyed you by criticizing your drinking? G. Have you ever felt guilty regarding your drinking? And then the big one, E, the eye-opener. Do you need a drink first thing in the morning to steady your nerves or get rid of a hangover?
That eye-opener question is chillingly specific.
It is, because it's a marker of physical dependency. Your body is in withdrawal. If a patient answers yes to 2 or more of these, you have a high probability of alcoholism, regardless of how many pints they claim to drink.
It cuts through the denial.
It cuts through the denial and identifies the risk. It's a powerful, simple tool.
Okay, so we've navigated the conversation, we've dodged the narrative traps, decoded the gestures, and calculated the real alcohol intake. Now, Hutchinson says it's time to get physical, the physical detective.
This is where we move from the abstract to the concrete evidence, the body itself.
And it starts before you even touch the patient. It starts in the waiting room.
Observation is free, and it's continuous. The text tells students to watch the patient when they don't know they're being watched. How do they get out of the chair?
What are we looking for there? What does that tell you?
Do they spring up effortlessly, or do they have to push off with their arms, using their arms to get out of a chair?
Right, kind of levering themselves up.
Exactly. If they use their arms, that suggests weakness in the proximal muscles of the legs, the quads and glutes. That could be a sign of anything from simple arthritis to a complex muscle disease like polymyositis. You've spotted a potential diagnosis just by watching them stand up.
And then the handshake. We mentioned this in the intro, but it really is a diagnostic tool.
The handshake is a data mine. An absolute gold mine. Is the palm sweaty?
Could be nerves.
Could be nerves, or it could be an overactive thyroid. Is it hot and dry? They might have a fever. Is it cold and blue? That's poor circulation, maybe Raynaud's phenomenon.
What about the feel of the hand itself?
Does the hand have a tremor? Could be Parkinson's, could be anxiety. And then, can they let go? There's a condition called myotonic dystrophy where the muscles contract but can't relax quickly.
So what happens?
You shake their hand and they literally can't release your grip. Their hand is stuck. It's a very specific, very rare, but very powerful diagnostic sign.
That's wild. The text also talks about posture as pathology. The idea that the way someone lies in bed can tell you what is killing them.
This is one of the most useful visual diagnostics, particularly in emergency medicine. Let's take heart failure.
Okay.
If your heart is failing, it can't pump blood effectively. So fluid starts to back up into the lungs. If you lie flat, gravity spreads that fluid out across your lungs, and you essentially start drowning from the inside.
A terrifying sensation.
It's a terrifying sensation of suffocation. So a patient with heart failure cannot lie flat. They have what we call orthopnea. They will be propped up on 3, 4, even 5 pillows, or they'll be sleeping in a chair.
So if you walk into a hospital room and see a tower of pillows, you immediately suspect the heart.
Immediately. Now, contrast that with peritonitis. This is an inflammation of the lining of the abdomen, usually from a burst appendix or a perforated ulcer.
Okay.
It is agonizingly painful. Any movement, even breathing deeply, stretches that inflamed lining and causes a shock of pain. So these patients lie stone still.
Utterly motionless.
They are rigid. They don't look at you. They don't turn their head. They are terrified of moving a single millimeter.
And then the third scenario in the book, kidney stones, renal colic.
The complete opposite. The pain is coming from a tube, the ureter, trying to squeeze a jagged stone through. It comes in waves of incredible intensity. The patient cannot get comfortable.
Right, they can't sit still.
They are writhing, pacing, rolling on the bed, desperately trying to find a position that stops the pain. So, heart failure sits up. Peritonitis lies still. Kidney stones thrash around. 3 postures, 3 very different diagnoses.
Let's zoom in now. We're going to look at the hands. The text calls the hands the biography of the body. I love that phrase.
It's poetic, but it's so accurate. Chronic diseases leave their autographs on the hands.
I want to do a really deep dive into clubbing. I've heard doctors throw this term around, but Hutchinson's goes into forensic detail. What are we actually looking at?
Clubbing is a deformity of the fingertips and the nails. And it's a serious sign. It's not something you ignore. It's associated with things like lung cancer, cystic fibrosis, and certain congenital heart defects.
But what does it actually look like? How can you spot it?
Okay, look at the base of your fingernail where it meets the skin. Normally, there's a slight dip there, an angle. We call it Lovey-Bond's angle. In clubbing, the tissue underneath the nail bed gets boggy and swollen. We think it's due to growth factors released by the underlying disease. That angle disappears. The nail lifts up and becomes convex, like the back of a spoon turned upside down.
And there is a test for this that listeners can do right now. Shamroth's window.
Yes. Try this. Put your 2 index fingers together, nail to nail, back to back, like you're making the top of a little heart shape with your fingers.
Okay, I'm doing it, pressing my thumbnails together.
Look at the space between the nail beds right at the cuticle. You should see a tiny diamond-shaped gap of light coming through.
I see the diamond. It's there.
That's Shamrock's window. If you had clubbing, that window would be gone. The swollen tissue would fill the gap entirely.
So if the window's gone...
If you ever do this test and you don't see that diamond, you need to see a doctor. It's a 5-second test that can spot a lung tumor. It's that powerful.
That is incredible. And there's so many others in the book. Koilonychia.
Spoon-shaped nails. But the other way, concave. The nail actually curves upwards at the edges, so much so that it could hold a drop of water.
Like a little bowl.
Exactly. That is the classic sign of severe, long-standing iron deficiency anemia. The nail bed is starved of oxygen and iron, so it thins and warps.
Yeah, and Beau's lines. This one was amazing.
These are fascinating. They are horizontal grooves or depressions running across the nail. They act like a timeline of your health.
How so?
Nail growth is expensive for the body in terms of energy. If you get really sick, say a severe infection, a heart attack, or go through chemotherapy,
Yeah.
the body shuts down the nail factory to save energy for survival.
It's non-essential at that point.
Exactly. When you recover, growth restarts. But that pause leaves a permanent dent. By measuring how far the dent is from the cuticle and knowing that nails grow about 1 millimeter a week, you can calculate almost to the day when the patient had that severe illness.
It's like counting tree rings to find the date of a fire.
Precisely. It's dendrochronology for the human body.
One more on the hand splinter hemorrhages. This sounds dramatic.
They look dramatic, too. They look like tiny little dark red or brown splinters trapped under the nail.
So it's not actually a splinter.
No, it's actually a little streak of blood from a burst capillary. Now, if you're a carpenter or a mechanic, it's probably just trauma, but if you haven't injured your hands, these can be a sign of something very serious, like infective endocarditis.
And remind us what that is.
It's an infection of the heart valves. Clumps of bacteria and blood clot break off from the infected heart valve. They travel down the bloodstream in the arm and get stuck in the tiny capillaries of the fingertip, causing these little bleeds.
So the heart is literally sending messages to the finger.
The heart is sending emboli to the fingers. It's a very specific, very worrying sign.
Moving up from the hands, let's talk about smell, because this is something high-tech scanners definitely can't do. The text suggests doctors should be using their noses.
Absolutely. The olfactory diagnosis. It sounds primitive, and it is, but it works.
The book mentions the smell of pear drops.
Or nail polish remover. That sweet, almost fruity chemical smell is acetone. If you smell that on a patient's breath, it's a hallmark of diabetic ketoacidosis.
What's happening in the body there?
Their body has run out of insulin and is breaking down fat for fuel way too fast, which creates these byproducts called ketones. Acetone is a ketone. It's a life-threatening emergency, and you can smell it from the door.
And then there's the obvious one, the smell of alcohol. But Hutchinson's gives a very stern warning here.
This is a major, major safety point. If a patient comes into the ER confused and smelling of booze, it is incredibly easy for staff to roll their eyes and say, oh, it's just another drunk.
Write them off, put them in a corner to sleep it off.
Yes. But the text screams, don't do that. And there's very good reason why.
Which is?
Because people who drink heavily fall over. A lot. They hit their heads. That confusion might not be the vodka. It might be a subdural hematoma, a slow brain bleed.
Oh, wow.
If you assume it's just intoxication and let them sleep it off, they might be slipping into a coma and they could die. The smell of alcohol is a clue, but it can also be a dangerous red herring.
Before we move on from observation, we have to talk about the face, specifically color. Jaundice is the obvious one, the yellowing.
Yellowing of the skin and, more importantly, the whites of the eyes. But even there, the text differentiates. A lemon yellow tint often suggests hemolytic jaundice, where red blood cells are breaking down too quickly, whereas a dark orange or almost greenish tint suggests obstructive jaundice like a blocked bile duct from a gallstone or a tumor. The shade matters.
And then cyanosis, the blue tint.
This is all about oxygen. But again, you have to be a detective. You have to ask, is it central or peripheral?
What's the difference, and how do you tell?
You look at the tongue. Central cyanosis means the blood coming from the heart itself is not properly oxygenated. You see it in the core of the body. The lips and especially the tongue will be blue. That's very serious. That's lung or heart failure.
Okay.
Peripheral cyanosis is when the hands and feet are blue and cold, but the tongue is pink. That just means the circulation to the extremities is poor. Maybe it's cold in the room, or maybe they have a condition like Raynaud's phenomenon. It's a crucial distinction. One is a local problem. The other is a systemic crisis.
One last visual that really stuck with me from the book, the butterfly rash.
Yes, a red rash that spreads across the bridge of the nose and onto the cheeks in the shape of a butterfly. It's a beautiful name for a serious sign.
And it points to?
It's practically a signature for systemic lupus erythematosus, or lupus, an autoimmune disease. You see that rash, and your differential diagnosis narrows dramatically.
Which segues perfectly into our next section. The logic of diagnosis. Thinking like a doctor.
This is the engine room. This is where it all comes together. We have all these clues, the history, the handshake, the smells, the rashes. Now, how do we put them together without making a mistake?
The text draws a sharp, sharp line between an impression and a differential diagnosis. Why is that distinction so important?
An impression is often just a guess. It's your first thought. It's, I think this is X. A differential diagnosis is a disciplined, rigorous list of all the reasonable possibilities, usually ordered from most likely to least likely or most dangerous to least dangerous.
It's a safety net.
It's a safety net for the doctor's brain. It prevents you from falling in love with your first idea.
Let's use the emergency room headache example from the book because it really makes the point.
Right. It's 3 a.m. A patient comes in screaming with the worst headache of their life. The easy answer, the impression, is migraine. It's common, it fits the symptoms. If you stop there, you're being dangerous.
Because if it's not a migraine,
Exactly. The differential diagnosis list forces you to ask, what else could this be that could kill this person? And the list would include a subarachnoid hemorrhage, a bleed in the brain. It could be meningitis. It could be a sagittal sinus thrombosis, a clot in the brain.
all killers.
All killers. If you treat a brain bleed with aspirin because you thought it was a migraine, you could kill the patient. The differential list forces you to actively rule out the worst-case scenarios before you settle on the common cold.
So it's a systematic way to check your blind spots.
It prevents what we call anchoring bias, where you latch on to the first piece of information you get and refuse to let it go.
The text also talks about weighing the evidence, that not all symptoms are created equal. They distinguish between hard and soft symptoms.
This is great stuff. A soft symptom is something vague and nonspecific. Tiredness, back pain, dizziness, as we talked about, wind.
Wind, I love that one. It's so British.
Everyone has wind. Everyone gets tired. These symptoms are so common, they don't really point to a specific disease. They're low-value currency in the diagnostic market.
But hard symptoms.
These are the gold nuggets. These are the things that make a detective sit up and take notice. The text lists things like pneumaturia.
Which is passing gas in your urine.
Exactly. Now, that is not vague. That basically never happens unless there is a fistula, an abnormal hole connecting the bowel to the bladder. If a patient tells you that, you practically have the diagnosis right there. It's a high-value clue.
Another one was rigors. What are those exactly?
It's not just shivering because you're cold. A rigor is an episode of violent, uncontrollable shaking, usually accompanied by a rapidly rising fever. That's not just feeling a bit fluish. That strongly suggests bacteria in the blood, which we call bacteremia, or a serious infection like malaria. It's a hard sign of severe infection.
And then the hammer blow headache.
The thunderclap, a headache that is of sudden onset, reaching its maximum intensity in seconds. Patients describe it as like being hit in the back of the head with a baseball bat. That is a subarachnoid hemorrhage until proven otherwise. It's a specific pattern that demands immediate, life-saving action.
So you collect the hard symptoms, but you also have to look for what isn't there. The text explicitly mentions Sherlock Holmes here, the dog that didn't bark in the nighttime.
This is the importance of negative data. It's a very advanced concept, but it's critical. Sometimes what is missing is the key to the puzzle.
Can you give us a concrete example?
Sure. Let's go back to chest pain. You're worried about a pulmonary embolism, a clot in the lung. We know that these clots usually start in the deep veins of the leg, a DVT. Right. So if you have a patient with chest pain, but their legs are not swollen, not painful, and they haven't been immobile on a long flight or after surgery, that negative data, the lack of leg symptoms, the lack of risk factors, helps you argue against the diagnosis of PE.
It doesn't rule it out completely.
No, but it shifts the probability. The absence of a sign is a sign in itself. It's a very Sherlockian way of thinking.
It's rigorous logic. It's not just intuition.
Well, the text actually has a fascinating debate about this. Pattern recognition versus logic.
Right. The idea of the expert doctor who just walks in and knows.
We call it a spot diagnosis. An experienced dermatologist sees a rash from across the room and says, that's shingles, instantly. They aren't going through a checklist. They're recognizing a pattern the same way you recognize a friend's face in a crowd.
But Hutchinson's warns against relying only on that, doesn't it?
It does. Because if you rely only on pattern recognition, you stop thinking. And if the case is atypical or a rare disease that looks like a common one, you will miss it. The text advises that experts must still verify their hunches with logic. You can have the aha moment, but then you have to do the mental paperwork to prove it.
So what does this all mean for the patient? We've treated them like a crime scene, decoded their gestures, smelled their breath, analyzed their logic, but they are still a person. Section 4 of the book covers this, the human element.
And this brings us right back to the author himself, Sir Robert Hutchinson.
There is a quote in the text. It's a petition he wrote in 1953. He was 82 years old at the time. And honestly, reading it, it gave me chills because it feels like it could have been written this morning.
It's remarkably prescient. Will you read it for us?
Yes. He prays to be delivered. From inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same.
Too much zeal for the new.
That hits hard in the age of AI and endless scans.
It does. Hutchinson was warning us 70 years ago about the seduction of technology. He was warning against over-testing, over-treating, and forgetting that there is a human being attached to the lab results.
And that last line, making the cure more grievous than the endurance of the same.
That is a profound ethical statement about quality of life. It's the idea that sometimes the brutal chemotherapy for a cancer with a very poor prognosis is worse than letting the patient live out their remaining time with dignity. Sometimes the treatment is worse than the problem.
And treating patients as cases.
That's the core of the entire book. You treat the illness, not just the disease. The disease is the biological malfunction in the textbook. The illness is the patient's personal experience of it, the fear, the loss of income, the inability to walk the dog. That's what matters to them.
This leads directly into the modern concept of autonomy. The text notes a huge shift from the old days of doctor knows best.
Yes. In Hutchinson's early days, the doctor was a paternalistic, almost godlike figure who decided what was best for you, and you did it.
Right.
Today, the text emphasizes that the patient decides their destiny. You can have the best diagnosis in the world, the best treatment plan, but if the patient understands the information and says no, that is their right.
Even if the doctor thinks it's the wrong decision.
Even then, the doctor's role is to explain, to advocate, to persuade, but ultimately to respect the patient's agency.
It's a humbling position for the expert to be in.
It is. It requires a deep humility. You have to accept that your medical truth is only one part of the patient's much larger reality.
So, as we wrap up this deep dive into Hutchinson's clinical methods, what is the big takeaway? We've gone from a simple handshake all the way to the ethics of refusal.
For me, the single biggest takeaway is that medicine is an art acquired by experience. It is not just a science learned from books or screens. You cannot learn the feel of a liver edge from a YouTube video or the sound of a specific heart murmur from a PDF. You have to be there. You have to touch and listen.
And the tools of the trade aren't just stethoscopes and MRIs.
No. The most powerful diagnostic tools are, and always have been, curiosity, listening, and observation. The ability to notice the spoon-shaped nail or the smell of pear drops. The ability to ask, what has led up to you coming here today? And then have the patients to actually listen to the answer.
It makes you look your own doctor visits a little differently.
It should. And it should make us value that human connection. Because no algorithm, no matter how smart, can hold your hand and notice that your palms are sweaty and you're terrified.
Here's a final thought for you to mull over. If Sir Robert Hutchinson were alive today, walking through a modern hospital with surgical robots and telemedicine and AI diagnostics, would he be impressed? Or would he see our reliance on technology as that zeal for the new that obscures the human being in front of us?
I think he'd ask us all to look up from our screens a little more often.
Next time you shake someone's hand, whether it's a doctor, a colleague, or a date policy, pay attention. Is it firm? Is it sweaty? Do they let go easily? What does that simple 3-second touch tell you about the person inside? You might be surprised by what you detect. Thanks for listening to The Deep Dive.
Stay curious.